I'm Mireille Jacobson. I'm the director of the Center for Healthcare Management and Policy here at the Hemorrhage School of Business at UC Irvine. I'm also a professor here, and along with Margaret Wong, who has disappeared, here we go. Margaret Wong, we want to welcome you to this event. She's done all the heavy lifting, so thank you, Margaret. Really appreciate all the work you've done. So before I hand things over to our distinguished panel, I want to just set the stage a little bit, provide a few statistics, some of which you may have heard already, and some of which hopefully will be new. So first, one thing that you probably hear a lot is that more people now die of drug overdoses than car accidents. And it's true today. It's also true at the peak of car accidents in 1972. So that's kind of a well-known kind of statistic that gets talked about a lot. What you hopefully realize is about 75% of those drug overdoses are from opioids, prescription pain medicines, and increasingly heroin and fentanyl. A few things you may not know. We talk about this really as kind of a white disease, and while the burden is disproportionate amongst white Americans, it is true that the rates of overdose are increasing, particularly since 2010, amongst other populations. So this does not discriminate. A few other things you might not know is that overdoses account for part of the actual decrease in life expectancy that we've experienced in the US since 2015, which is really, after decades of increases in life expectancy and very unique to the US, not our kind of peer nations. Although we've increased the use of prescription pain medicines, the thing that hasn't really budged, if anything by some measures has increased, is chronic pain. So if you look at measures of chronic pain, we haven't really made a dent in it. If anything, it's increased. And then finally, the burden does vary enormously geographically. So this is more of a rural problem. This is kind of true. So if you look in California at the 10 most rural counties, last year there were more prescriptions in those counties than there are residents. So I think that's an interesting marker. So with that, I will leave you on a positive note, which is that despite occurring in high numbers in California, so we're a large state, we are actually amongst the lowest in terms of per capita overdose deaths. So that's a bright spot, although the trends are really kind of not abating. So with that, I'm going to turn it over to the experts who will really tell us more about the epidemic on the ground here in Orange County. First, we have Dr. Richard Bock, who is the Deputy Chief Medical Officer with CalOptima, who will give us a health plan perspective, and in particular, a Medicaid perspective. Sandra Fair, who is retired as the Chief of Behavioral Health Operations for the Orange County Healthcare Agency, who's going to provide more of a public health and county behavioral health perspective. And Dr. Chakravarthy, who's an Associate Professor of Clinical Emergency Medicine and Public Health at UC Irvine, and the lead on the Orange County Prescription Drug Overdose Collaborative. He's going to give us more of the front lines of medicine perspective. And I should say their detailed bios with all their accolades are on your table. I want to get us right to the heart of this. So please look at that at your leisure. So please join me in welcoming them all, and I will turn it over.
Good morning. I'm really pleased to be here this morning with Drs. Bock and Chakravarthy to discuss how opioid issues are affecting Orange County. If you look at this quote, it talks about how big the problem is in the United States. In this quote, Keith Humphreys compares Japan to the United States and says that if you looked at the daily doses, the consumption of opioids in Japan, and then you doubled that number, and you doubled it again, and then again, and then again, and finally you doubled it 5 times, Japan would then come in second to the amount of consumption in the United States. The CDC has indicated that prescriptions have quadrupled since 1999 to 2014. But there is no change in the pain that's been reported by Americans in treatment. The healthcare agency recently produced a report called the Opioid Overdose and Death Report. And that report was to look at how the crisis was affecting Orange County. And it looked at 3 areas. It looked at prescriptions using the Cures data. It looked at the number of emergency department visits and also hospitalization data from OSHPD. And it looked at the death data as reported by the Orange County Sheriff Coroner. And looking at those things enables us to look at what resources are available in Orange County to address it, and also what additional responses are needed. In Orange County, almost half of 4 million prescriptions that were given out to residents in 2015 were for opioid analgesics. A total of 1.7 million prescriptions for opioids were given out, and the average prescription was for 72 pills. That's over 122 million pills in 1 year alone. And a preliminary review of the Cures data for 2016 indicates that that number has gone up by about 3% and to over 127 million pills being dispensed. Now, I want to make clear that the Cures data does not address the dosage levels of the prescriptions, nor does it relate it to population data. So I don't want this to be a statement that more people are getting more drugs, more powerful drugs. This map shows the opioid prescriptions by patient zip code in Orange County in 2015. If you look at the dark blue areas, those are the areas with the highest numbers of prescriptions. You can see that those pretty much focus on the coastal areas of Orange County and the southern region of Orange County. On average, 563 prescriptions are dispensed per 1,000 residents in Orange County. But if you look at those dark blue zip code areas, they range from 643.6 prescriptions to 1,189 prescriptions per 1,000 residents here in the county. When we look at the emergency department hospitalization and death rates for opioid overdose, we can see that the death rate has remained relatively consistent in Orange County, but sadly, of course, it is continuing to increase. The hospitalization rates have gone up and down and up again, but generally have increased. But if you look at the green line, the emergency department visits are dramatically increased over the last few years. The rate of emergency department visits has more than doubled since 2005. So there were 1,769 visits to the emergency department in 2015. In 2016, according to available data, it appears that that number is increasing by about 29% above 2015. And as you can see, the emergency department visit zip codes relate very closely to where the prescriptions are being received. Again, it is our coastal areas and our South County regions. So between 2011 and 2015, an average of 1,500 county residents were treated in the emergency department. Data indicating that that average is now increasing to over 1,600 per year. Roughly 6 out of 10 are males. That's about 906 per year, while females make up about 39% of the population that presents in the emergency department. This is a glass ceiling that women have not yet broken, but unfortunately, the number of emergency department visits, the number of overdoses is increasing dramatically for both males and females. When we look at race and ethnicity of who is reporting, as Dr. Bock mentioned, and Dr. Jacobson also mentioned, we see primarily non-Hispanic whites presenting in the emergency department at a rate of 87.2 persons per 100,000. And that's followed by African Americans has the second highest rate, although the lowest number of cases. That has to do with population data. And then followed by Hispanics at about 21.5, the rate of 21.5 per capita. Looking at the age groups, adults between the ages of 18 and 34 comprise more than half of those who were treated in emergency departments. The highest number, as you can see, at 425 is between 18 and 24 years old, followed by those 25 to 34 years old. And then the next highest group goes up to the 45 to 54 and 55 to 64 years old. The number of emergency department visits has increased for every age group except for those between the ages of 10 and 17, which at least is a hopeful sign for right now. When you look at the death rates, the United States death rate has increased 55% since 2010. The California death rate has increased 2% during that same time period. Orange County consistently exceeds the California death rate, and it has increased 12% over the same period of time. And again, going back to the 2016 data, it looks like that is increasing dramatically for the year following this. The overdose deaths, if you break them down by what is causing the deaths, 55% are due to opioids. That is prescription opioids, followed by a mixture of drugs and alcohol or other drugs such as benzodiazepines, and then illicit substances such as heroin. Most frequently, the opioid deaths have, 66% have a natural or semi-synthetic opioid was involved in these deaths. That's 801 of the deaths. And most frequently found was hydrocodone, followed by morphine, then heroin, oxycodone, and then codeine, which comes up far last. 81% of the deaths were accidental, and with 15% suicide and 4% the sheriff coroner could not determine whether it was intentional or unintentional. Again, if you look at who is dying, primarily 62% of the deaths are males, 38% are females. There are about 149 men per year who are overdosing, and about 93 women. Nearly half of the opioid deaths were between the ages of 45 and 64. The adults aged 45 to 54 had the highest rate, and then followed by the ages 55 to 64. And then, unfortunately, the third highest rate is those who are 25 to 34 years old. It's important to note that the majority of the overdose deaths are adults, middle-aged, dying of an accidental overdose on their prescription drugs. And again, if you look at the demographics, it is primarily non-Hispanic whites, followed by Hispanics, and then your Asian Pacific Islanders and African Americans. The African Americans, there is a low population rate, so it's a little bit difficult to use the population data on that. The geographic distribution, not surprisingly, correlates to the emergency department visits and where the people are receiving their prescriptions. The highest rates are in the coastal and South County areas, including the cities of Laguna Beach, Laguna Woods, Dana Point, Costa Mesa, Laguna Niguel, Huntington Beach, and Laguna Hills. And what's really alarming is that the south part of the county, the southern region, has experienced the highest increase in overdose deaths at a 21% increase between 2011 and 2015. So, given those wonderful graphics of what is going on in Orange County, we need to look at what the county's response is to the opioid issues. All the stakeholders recognize that this is a critical public health and safety issue here in the county, and everyone is taking actions to address it through their appropriate channels. As you heard from Dr. Bock, he's working very closely in CalOptima to address this. One action that is being taken is that the Orange County Alcohol and Drug Advisory Board is working with the healthcare agency to develop a strategic plan to do so, they're identifying individual and community needs and then looking at what would be effective strategies to address those needs. The strategies focus on the 4 areas that are really vital to addressing the issue: prevention, harm reduction, treatment services, and recovery support services. And what they're looking at is they're doing an assessment by putting out the word through surveys. They've done online surveys and hard copy surveys, key informant interviews, and focus groups. And then we're looking at providing a large community planning meeting at the end of January. I believe it's January 24th. And then a report will be prepared and provided to the community and policy leaders here in Orange County. Doing a cursory review of the responses received to surveys to date, it's very interesting to note that, not unexpectedly, most of the people were getting their drugs initially out of their parents' medicine cabinet, from friends, buying it on the street. Just an anecdote of how pervasive this is. I have a friend who went to the dentist and had some work done, and the dentist gave her 30 Vicodin. Well, she didn't take any of the 30 Vicodin. But then she's at work and somebody was complaining about their sciatica, and that person walked away with 30 Vicodin. And my friend had no idea she was contributing to the problem. She does now, but at that point she didn't. But what most of the respondents are saying, and we surveyed current and former opioid users, community stakeholders, family and friends, and substance use treatment providers. And across the board, they've identified that the people most in need are young adults and people who suffer from chronic pain. The services that are most needed are those that address both mental health and co-occurring substance use disorders, that physicians need more training on prescribing policies and how to protect their patients, and that, of course, timely access to treatment is vitally needed for people who have no funds to pay for it. The challenges that people face when they related to treatment are cost is number one, and also what we see strongly is the willingness to get treatment or the denial that people need treatment, and also that people may not know where to get treatment. They may not know how to contact a treatment provider. So we're continuing to look at that data as we get more responses. There is a flyer on the back table, I'll do a little advertisement, that has the SurveyMonkey links, and it also has an email address to contact if you have any questions. So that is one strategy. We also have a website that is totally related to opioids, and it addresses prevention and treatment resources here in Orange County. In the areas of prevention, as I mentioned, most people are getting their drugs through the family or through their friends. And there are many medical disposal drop boxes throughout the county. Unfortunately, most of them do not take controlled substances. But there are national take-back days. There was one on October 28th that was very successful here in Orange County. Also, one of the things that's being widely touted is teaching people how to monitor, secure, and destroy their drugs. And there's a prevention collaboration in Mission Viejo that's working very hard on this and posting flyers all over the south part of the county in pharmacies, dentist's office, coffee houses, to help people learn that they can destroy their medications at home. Also, in the area of prevention, certainly our health providers and our collaboratives are critically important to this. Dr. Bock, as you've heard, works with CalOptima, and they have done a great deal to address the problem with Medicaid recipients and to monitor the prescriptions and misuse of drugs. Also, SafeRx, and I'm sure Dr. Chakravarthy will tell you more about that, is a county-wide collaborative that is really looking at bringing all the parties together to combat drug abuse and overdose deaths. In community prevention services, HCA provides a wide range of services, both through behavioral health services and also through public health, the alcohol and drug education prevention team. What is done is there are school-based curriculums that are provided throughout Orange County. There are educational workshops that are done through schools and through prevention providers to do family strengthening and also parent education on things to look for, such as what are the signs that your child may be abusing drugs or what other risk factors they may have. The prevention activities are universal type prevention activities and also very directed prevention, because the thing we know we need to do is to reach those people who are most at risk. In the area of harm reduction, we know it's critical because only the living can recover. And Naloxone or Narcan availability has greatly increased. Pharmacies are supposed to be carrying it. We encourage emergency departments to keep it, for primary care physicians, as Dr. Bock mentioned, to prescribe it when they're prescribing opioids. It does need to be everywhere, as he said, hanging from every bus stop. The Solace Foundation has done an excellent job. They have teamed up with the Needle Exchange Program here in Orange County, and they provide naloxone to the user community, and that has saved thousands of lives, while the Needle Exchange Program has done a wonderful job at harm reduction in reducing the transmission rates of Hep C and also HIV. They're also working really closely with public health, for example, with the hepatitis A situation that's come up recently. The Needle Exchange Program, Solace, and the public health nurses all got together to vaccinate people to make sure they were recovering. Of interest is that the Board of Supervisors just recently accepted a grant for over 6,200 doses of naloxone, and those will be provided out in the community to those most in need, and through the Solace Foundation and to treatment providers. If we look at the area of treatment, there is a continuum of care available for people who need publicly funded services. But funding, of course, is always a limitation. And as a result, services are not always readily accessible. For example, if you are not privately insured and you need publicly funded residential treatment, you're going to wait to get into residential treatment, unfortunately. So Orange County has submitted a plan that has been approved by the State Department of Health Care Services and Centers for Medicare and Medicaid to become part of a 5-year demonstration project for to provide a drug Medi-Cal organized delivery system here in Orange County. Essentially, that means we will become a managed health plan for substance use disorders. And this will enable more people to get the recovery services they need and to engage in treatment and to sustain their recovery. Services will be provided that are medically necessary, as opposed to just getting the services where you've shown up and they have an opening. It will be based on the diagnostic criteria and also ASAM to get appropriate level of care. But what we do know is that regardless of the level of treatment, if a person is in detox, residential, or outpatient services, medication-assisted treatment, the use of methadone, Vivitrol, Suboxone, those are all critically important to helping people to retain them in treatment and to help them sustain their recovery. And we also know that the use of medication-assisted treatment is benefited by the co-occurring behavioral health services. That you can go to your doctor, and primary care physicians can certainly prescribe MAT. That's wonderful. If they are linked to a behavioral health treatment service, that's even better. And we know that integrated care with physical health and coordinated care with mental health is vital to all of this. We do have an MOU with CalOptima to serve our Medicaid population, and it's working very well. And we are a behavioral health services county. That means we do not have silos of substance use, a substance use department and a mental health department. Co-occurring and co-located services are provided at all the county locations. So I'd just like to point out that there are other ways we reach out to people. We do have an outreach and engagement team that's funded through the Mental Health Services Act, actually, but it is focusing on the homeless population here in Orange County. They are out at the riverbeds, they are at the homeless shelters, and they are working very hard to connect people to treatment, either for mental health and or substance use services. We do support the NAMI Warm Line, which is for non-critical situations where they need someone to get some assistance from and talk to, and of course the 24-hour suicide prevention line. And most importantly, we have in the Healthcare Agency Behavioral Health Services a navigation system called OC Links, and this is an information and referral phone line and online chat service, and this helps people navigate the behavioral health system within the healthcare agency. This is for children and adults, and I looked at the data from a couple of years ago, and well over half of the calls that they received during a one-year period was for information and referral services to substance use treatment. So you can see what an incredibly large problem it continues to be. And in this system, the navigator, who is a clinician, will link people to a program while they're talking to them and hopefully do a warm handoff. If you'd like more information about the Opioid Report, it is available online. If you can read that, it's at ochealthinfo.com about admin, pubs, and opioids. So if you go to Orange County Health Info, you can get to it. And there's also a story map there that gives you more maps of what's going on. But I really appreciate your interest in this. Thank you very much for listening.
We need a doctor to bed to stat. We need a doctor to bed to stat. It's a pretty common, uncommon overhead page that I hear in the emergency department. I've been doing this for 10 years since I graduated from residency. Not very much excites me, but when I hear that word over the intercom, I actually get excited. I know it sounds perverse, but I get excited. I feel like I'm actually useful and I can go and do something. So I heard one of these stat calls, and I walked down, kind of briskly walked down the hallway, and I see a pool and a trail of blood that leads to bed 2. And I see this young man whose hand looks like somewhat like this. It's not his actual hand, but very, very similar. But with open wounds that are actually squirting out blood. He has both wounds on both of his hands that were oozing out blood in one hand and squirting out blood in the other hand, and primarily from injection drug use. And so as I'm sitting there going through my usual algorithms that I've learned over my training period, you think about hemorrhage control and blood control. And so long story short, we were able to, with a great difficulty, stop the bleeding. And this gave me some time to actually sit down at the bedside, which is pretty unusual in healthcare. As you guys know, we're all geared towards seeing as many patients as we can due to the economics of healthcare. But in times like this, you actually have a moment, and this was a moment I got to hear young Billy's story. This gentleman was about 35 years old, and I said, you know, what happened? And obviously he told me about his heroin use. And I said, how did this all start? Well, interestingly enough, it started when he was a high school student. This is not a picture of him, but a depiction of what he might look like. And he was in high school playing sports in South County, in Orange County, and he got injured, pretty bad injury, a knee injury. And as anyone knows, these orthopedic injuries can be very painful and require analgesia, pain medications, which is completely appropriate. He received opioid pain medicines for home after he had his surgery, and one thing led to another. So he had built up tolerance to the pain medicine, which then led to misuse, which led to abuse, which eventually led to addiction, and then slowly and in a slippery slope went to heroin abuse. So I think what I'm trying to say is this is not an uncommon scenario, and as healthcare providers and leaders in this field, I think we should be very cognizant, and I think we know this already, but just to kind of put this point in fact is heroin and opioid abuse is not a moral failing. It isn't. And I think it's easy for us to think that. He said, oh, how did this all happen? He's a drug abuser. He's like the scum of the earth. And, you know, everyone has a story. And I you know, it's a series of maybe 2 or 3 unfortunate events. I could be that person too, you know. And so I think every time this happens, I remember when you know, there's a whole bunch of stuff going on in my life, but I have this imaginary line when I go to work. Last night when I went into work, I said, okay, this is the line where I'm focusing on my patients and I'm trying to put myself in their shoes. And that's what hopefully will give you a little bit of understanding. I'm going to give you a little bit of historical context. I think we've heard a lot about that today already. But, you know, how did this all start? Well, as physicians, as providers, what do we want to do to our patients? We want them to make them feel better, right? We want to feel useful. That's a human characteristic. And people come in with, a little kid comes in with an earache. My wife's a pediatrician. What do they want? Antibiotics. They want a pill. They want to feel better. They think that the pill is going to make them feel better. Some cases, it will. Maybe they really do have otitis media or a middle ear infection, and it's a bacterial infection. About 80% of the time, it's not. It's a viral infection. But having those difficult conversations with your patients, with those expectations, is challenging. So when people come in with pain, we want them to feel better. We do. We want them to feel better. We want to give them pain medicines. But our society demands pills, right? That's what they want. They want medicine. They want pills. They want an immediate quick fix, fast food, fast medicine. That's just the way of the world. It's our job, I think, as leaders to kind of change that paradigm a little bit, to have those conversations that might affect my patient satisfaction scores, which is another whole topic, but we won't get into that. Mine are excellent. Not true. Okay, I'm working on it, though. I'm working on it. But, you know, we heard some of these stats. You know, so this is from last year. The number of prescription deaths are ridiculously high. The number of opioid deaths are a good majority of those prescription deaths. We see that it's kind of overcome the motor vehicle collision deaths, which has been a huge public health issue and still remains a public health issue. And then just to put it in perspective, that terrible day in 9/11, we had almost 3,000 deaths. So not to take anything away from that day, but we have this going on every year for many, 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 many years. We talked about how the pendulum has kind of swung a little bit. You know, so when I was a medical student and a resident, in 2002, you know, I trained in New York City, and we used to give non-steroidal anti-inflammatories for kidney stone pain. I think I was probably, you know, that was not nice, and so we were under-treating pain. But we have ridiculously swung the pendulum the other way, where now we are automatically prescribing 90 pills of oxycodone and Percocets for whatever it might be, post-surgical, when you come into the emergency department, or just having those difficult conversations with the primary care doctors with their patients because they've known them for a long time and they keep coming back and they're, again, developing tolerance and maybe misusing it and potentially abusing it. It's a slippery slope, and those conversations are really, really challenging to have. We heard about Purdue Pharmacy and what wonderful work they've done. I'm being facetious, obviously, but there is a strong pressure with pharmaceuticals and medical device companies in the United States. Believe me, everyone in the world wants to get treated and have care in the United States. There's no doubt about it. We are the best healthcare system in many, many respects, cutting edge. But we have a long ways to go, and I think we are also influenced by these industries, and we have to be aware of that. And so, I apologize from our standpoint that we feel like we can't be influenced, right? We're like, oh no, sure, let's have I remember back in the 80s and 90s, it would not be uncommon where people will hand you tickets to go to the opera or go see a baseball game or something like that. And I'm talking about pharmaceutical industries. So they've since cut all of that out. And you think, oh no, yeah, it's cool. Yeah, we're going to go see the Yankees game. That's going to be fun. Yeah, it'll be great. But those kind of things add up and influence you. And then they get into, your Rolodex or your cell phone and stuff like that. And so this is what happened in the 90s and early 2000s. We saw this already. The number of sales with prescription opioids really mirrored the number of deaths. There's no doubt about that. And then here's sales, deaths, and treatment. That all kind of parallels. You can't get a better shadow. It's perfectly fine, perfectly symmetric. And then here's another thing that you've heard already. But it's not just the number of pills, but it was a concentration of pills, right? Everything is in potency. So, my father always used to tell me that do everything in moderation. Like, don't go crazy, right? Just like you have a small piece of cake, you have a small piece of cake. Don't eat the whole cake. So, it's like do things in moderation. And I think that's. But here we go. We have stronger morphine dose equivalents of opioids that are being prescribed. Why? Because your patients are demanding it, right? Why? Because they're developing tolerance. It's tough, but this is what has happened. How are we doing here in California? We heard Ms. Fair talk a little bit about that, and Dr. Bock. But here's that red line in the middle is the average of the number of opioid deaths in 2016. Here's Los Angeles County, just to put it in perspective. You think of big bad LA, and I don't want to drive past. I have a neighbor friend, who was born and raised in Irvine, and I wanted to take him out to dinner, and I said, let's go to Santa Monica. It'll be really cool, And he's deathly afraid to go past the 55 freeway. I'm like, come on, Chris, let's do it, man. I will drive. I got you. He's deathly afraid. But you think of big bad Los Angeles County? Not that bad, right? And then here's San Diego County, our neighbors to the south. And here we are in Orange County. We're overachievers. We're doing pretty good here. So, and then you see Inyo County up there. Has anyone been to Inyo County? Nobody. Oh, just one, maybe a couple of people. Yeah. When you drive up to Mammoth Mountain, if you guys are skiers, you're gonna go through Inyo County. But it's a rural problem too. And then you've seen this graph already, Ms. Fair, and I think Dr. Bock already showed you this. This is coroner's death data. It's really, really, what I take away from this graph is it is a coastal and South County problem, but it's also a total county problem, right? It's not, but those are some focus areas, and so it doesn't, this epidemic doesn't know racial, ethnic, socioeconomic boundaries. It's everywhere. So here's a number of prescription deaths in that same kind of graph, and then again heroin deaths, right? So we kind of split them up. We did all opioids, we did prescription heroin. They really kind of mirror each other, and you can kind of put them on top of each other. So who's prescribing these medicines? Who's to blame? Well, a lot of studies. You probably heard this in the lay press as well. But most prescriptions come from primary care physicians. Most of them do not specialists. Most of them come from primary care physicians. And, we had some studies that shows that 20% of prescribers account for 80% of the prescriptions. So what I take from that is that's a teachable moment. That's an educational opportunity. That's a public health effort, right? There's 20% of people prescribing 80% of the meds that could be potentially harmful, there's an area. Now, you might say, well, a physician might say, well, my patients are really challenging, or I have a lot of chronic pain patients. Sure. This is the argument I get at UC Irvine when we're trying to develop just educational efforts surrounding some metrics. CalOptima and Dr. Bock's team have done some wonderful work with sending some love letters in analyzing the average number of prescriptions per specialty and sending them an educational letter, not punitive, purely educational. And I thought that was fabulous, and I wanted to incorporate that. So I'm on the pain committee in my hospital. Boy, I'm not getting any Christmas gifts. It's just a lump of coal for me. And I was astonished. I was like, no, it's just like, it's data. Can't tell doctors what to do. They will get pissed off. A lot of egos. So anyways, in LA County, you see the stats here. So I really think there's a teachable moment. We can really educate our physicians. I think it's going to take time. I'm not a doomsayer. I think with time, we can change culture. Here's some statistics about where people are getting their meds for non-medical use, right? Not surprisingly, this gray graph bar indicates given by a friend or a relative for free. Ms. Fair just told us about her friend. It's not uncommon, and I don't think people mean well, right? I went to India just last April, and I just loaded up. I was like, I'm getting Cipro, Zofran, and some like anti-diarrhea pills, and I didn't use them much, and I came back home and I hoarded them. I'm not going to dispose of these medicines. And there's Cipro and Zofran and they're not that dangerous, and I'm a physician. But you can see that when patients get prescribed medicines, they're like, what if I get that little twitch behind my ear? So you have to educate patients and make sure that they safely dispose of these medicines. All medicines have a therapeutic window, but they also have a side effect profile. And some of them are smaller, those therapeutic windows. So we have to be really cognizant. So what about priming versus substitution? We talked about this a little bit. Do we prime patients to become addicts? Do we prime them to be heroin abusers by prescribing pain pills? Probably there's some of that. Or are people who are addicts substituting their medicines and getting them wherever they want? There's probably some of that too, but that's kind of an ongoing area of research. And it's very intriguing. Certainly we know that if people receive prescriptions for pain pills, that they're more likely to abuse them at a later date. And then if it's cheaper to get heroin and street drugs instead of going around and seeing how you can get them from the healthcare system, then people are going to find a way to treat their physiologic need for these medicines, right? You're changing receptors. Your body is craving for it. I don't have a cup of coffee in the morning and I can't talk to my kids. It's like impossible. So and that's coffee, that's coffee. We're talking about opioids here. All right, we've seen this already, so I'm going to pass through that real quickly. And here's an interesting graph. So we see the number of prescribed opioids, maybe leveling off a little bit, and this was a little bit of dated information from 2014. But then you see a heroin spike, right? So this is a little dangerous. So our first thing in the Hippocratic Oath is to do no harm. So yes, we're part of the problem. Yes, we caused the problem, but let's not cause another problem. So we have to be very cognizant of that and make sure we deal with this in a holistic manner. But I'm very data-driven. I did a research fellowship, so I want to follow the data. And so, this really shows that substance abuse or dependence in the previous year, for people with heroin abuse, many of them have been prescribed opioids. It's not rocket science that they've also have alcohol, marijuana, and other illicit drug issues. But you could see the numbers there with the p-values really ridiculously high. And this is the annual average of rates of heroin use during the past year. You see those rates for non-medical use of prescription opioids during the previous year drastically go up from 24% to 138%. Again, nothing that I'm not telling you. So we have a lot of problems, right? We have the historical perspective. We have, poor Johnny that we talked about earlier, who came into the emergency department. What are some solutions? We heard about some solutions. Well, in public health, at least, we think about the 3 E's, right? Education, enforcement, and environment. So we kind of focus on those areas, and I think that has been a good way to think about it. And education is really important. So what we did, just as a pilot, I think the one thing that's really cool about my job is I get to really mentor and be around students and young minds, and I think there's something amazing about that. And I, besides the free labor that it usually comes with, they get to do all my projects for free, but they get a letter of recommendation at the end and maybe get into a good residency program. So free labor is good, and they're very sharp, and they've taught me some cool things. So they did this. We figured out that patients really don't know what's going on. I have literally 3 minutes to spend time in the emergency department. I think this is the same with all physicians out there. They're very pressed for time. How are we going to educate patients? The nurses are really the front line in most cases, but especially in my ED, the nurses do all the work. But they're also stressed. They're seeing a lot of patients and managing a lot of things. So we thought, hey, let's make a little Khan Academy type video. Let's educate our patients while they're waiting, right? What do you do in the emergency department besides getting treated? Wait. You wait, and then you wait, and then you wait. So we said, hey, if we're going to prescribe opioids to people, maybe like right as we anticipate their discharge, let's show them this little 6-minute video. And this is a little video that was created by a medical student. Khan Academy
are
video.
Powerful drugs used to treat pain. Opioids include drugs like Vicodin, Demerol, Percocet, Dilaudid, Norco, Ibuprofen, Suboxone, OxyContin, and Tylox.
A lot of this information was taken from
Opioids
SAMHSA,
are known
the
as
CDC
drugs
website.
of abuse because of their addictiveness and the sense of well-being they give when used improperly. This is because they're very similar to heroin and opium.
The hardest part of this video was picking the
Opioid
music in the background. I didn't know
painkiller pills may
what to
contain
pick.
other
We
substances such as
tested it with a whole bunch of, we
acetaminophen
put some
and
Metallica
ibuprofen.
on there. We put some
These can
Tupac. I
also
was
be
like, I'm not
found in
sure
drugs such
where we're going
as
with this,
Tylenol,
but this is the one we settled on.
Alka-Seltzer, Cepacol, Dayquil.
Anyways, it goes on for 6 minutes. It's short, and everyone has a short attention span these days, and so we created what we thought was a high yield video, and we did a knowledge acquisition study, and voila, yes, they are able to retain that knowledge. And the 2 areas that we found in patients that they lack knowledge was safe disposal and the side effects of opioids. So I'm like, oh, wow. And that was knowledge acquisition. That was literally like 5 minutes after they saw the video, they took a before and after quiz. So we're following that with knowledge retention, and then obviously we need behavioral change, right? But we start somewhere, and that's like a small little project. And then we talked about cures or California's prescription drug monitoring program. There is a law that requires all physicians and pharmacists to sign up for this program. I personally think that's great. I think also that Cures has a second version. It's called 2.0. It's been out for now a year and a half, 2 years. And we are really trying to help incorporate that into everyone's practice, namely making it easier so that we just incorporated a new EMR, electronic medical record system, last weekend, and it was yeah, it was something else. And so it was epic. That's what it's called. It's called Epic. It was epic. I will tell you, there was a tidal wave of epicness. And I have like 100 charts to do. I don't even know how to open that thing up, but I will figure it out. So anyways, we want to incorporate it into the EMR, so it makes it easy for us, right? It makes it easier for the people using it. So you go click, and it's a single sign-on, and you're like, oh, wow, can that tell me that, Miss Johnson or Mr. Patel just got 100 pills of Vicodin just a week ago? That would be really cool. And it would be incorporated into my daily practice, and then I'd be able to make those decisions, because more data is better than less data, in my opinion. But there are some mandates and some ideas of forcing people to use it, and I think that's, again, telling physicians what to do. We talked about that earlier. And also, they're changing, this prescription drug monitoring program is housed in the Department of Justice in California. It's now really so it's really a law enforcement database, but over the last 3 to 4 years, they've really tried to incorporate public health and providers into how to use this valuable information and not just for law enforcement. So I think it helps in both respects. There's a lot of different tools out there and a lot of information if any of you are interested in it, but safer prescribing is one of the things we want to do. So primary prevention, we really want to make sure physicians know how to have these discussions with their patients, right? And so it's tough because someone comes in and they says, I tried to make an appointment with my doctor. I have this really bad sciatic back pain. I ran out of my Vicodins. Not uncommon. This happens all the time. And I'm like, gosh, I'm not this patient's doctor. I know if I keep prescribing these medicines, am I fueling his tolerance, and is this going to lead to something worse? And but I have this piece of paper, and I can go, sir, we have a policy here. We have this paper. Don't get mad at me. This paper right here says I cannot prescribe more than a few days worth of medicine. It's not true. I can prescribe whatever I want, but at least I have that information, and the patients feel like, oh, okay. They're still going to get pissed at you to some degree. But I mean, at least it makes you feel better, and the conversation is focusing on the paper and not me. And who knows what my Press-Ganey scores will turn out to be. That's our satisfaction scores. I don't know if you guys know these Press-Ganey scores. They are absolutely, from a scientific standpoint, the earth is flat, I tell you. It's we're making national decisions on this nonsense. Anyways, speaking of, see? It's patient satisfaction scores. But it is a pressure. Our group, even though we're an academic group, we want to make sure the hospital wants to know, are you seeing patients on time? Are you treating their pain? Are you getting good scores? Because we want to be nice. We want to help our patients. I know I'm very sarcastic, but we want to be nice, and we want to help, and we do care. But there are so many different forces, seeing patients on time, seeing 40 patients in 8 hours, getting your charts done. There's so many different things, and this is not just with physicians, with nurses as well. It may sound like an excuse, but we have to also be cognizant of these other policies that are out there. We spoke about naloxone a lot, and I really do believe that naloxone, some people really feel like it may be enabling patients. I don't think that's the case at all. And I think when we talk to why physicians and providers don't consider naloxone, I think it's multifactorial, but one of them is kind of they believe that it could be helping enable them to use more drugs. It's not going to cure them, but it's going to help them and keep them alive to the point where maybe the second, third, fourth, fifth time they encounter the healthcare or system that we can get them to help. And this was a cool study. Emergency department initiated buprenorphine naloxone treatment for opioid dependence. I thought that was really cool. It's done by some of my esteemed colleagues in Yale. They're awesome over there. They do really cool stuff with public health in the emergency department. And so what they did was they prescribed. So they did a brief intervention, referral to treatment, and started them on Bup. We call it Bup or Suboxone or buprenorphine. Started them on Bup, and then followed them up in 30 days. And we did see some success in terms of the their inpatient addiction days and the number of pills, self-reported pills. This just reminds me that educating patients about safely disposing of their medications is really important, and there's many efforts that are going on out there. I think we can do a heck of a lot more. Coffee grounds, so smashing up your pills and mixing it with coffee grounds or eggshells or something like that, and then throwing in the garbage is the best way, other than safely disposing of it at pharmacies and take-back days. But that's something that we can do a heck of a lot better. And just in summary, there's a lot of information out there. We're working on a lot of projects, and I think it's we have this Orange County Collaborative on curbing the opioid epidemic, and it's called Safer RX OC, and there's a website, and my email should be somewhere over here. yeah, thank you for your time.